We are going to look at the coronary artery disease. As a prelude to that, as an important thing is you must know the CHD risk approach. First of all, we are getting the CHD risk approach and then go to the coronary artery disease. So it has got two sections. Section 1 is about the CHD prevention is the mantra. Overview of atherosclerosis will be there. And also you have the risk factors in detail. You will know all the risk factors. And the second part, of course, is the patient evaluation, risk scoring tools, and then the management of the risk factors. And finally, the take-home message. It will take maybe around two or three classes it will take. Today, we are going to see how far we can. Okay. So very alarming. India is the diabetic capital of the world. Indians have one of the highest rates of coronary artery disease. And Indian coronary artery disease is a special entity. It is called CADI, coronary artery disease in Indians. There is chapters and chapters are written. There is one book on CADI by Enas, who works exclusively on coronary artery disease in India. So it is such an important subject for India. And the highest coronary artery diseases in the world, one of the highest coronary artery disease rates are found in this country. And it is malignant in its onslaught and occurs very early in this country compared to other countries. Obesity in India is threefold compared to what it was 1990s. People are daily eating lots of Zomato, Swiggy and all that. With the result, they are available for cardiology and doctors. It is high time all of us collectively do whatever best is possible in preventing this worsening. Okay. So when you are in the theater, there will be several exits. For the theater of this world, there are only two exits, exit 1 and exit 2. Exit 1 is the end of the show. There are two exits. The first exit is cardiovascular disease exit. 50% or more of the people have to die through cardiovascular diseases. And all other these cardiovascular diseases is coronary artery disease, cerebrovascular disease, peripheral vascular disease, renovascular disease. These four are together are called the cardiovascular diseases. That is coronary, cerebral, peripheral, renovascular. All other causes put together, like your suicides, accidents, cancers, autoimmune diseases, any other disease, infections, think of any other disease, 50%. So where should your money go? Where should your effort go? In preventing the cardiovascular deaths and in treating the cardiovascular deaths. So this, remember, such a grave situation we are all are here. Now, we are all sitting on a volcano. This we never know that we are sitting on, you are sitting on a chair. No, you are not. You are sitting on a volcano. It is going to burst anytime. If you don't realize that, time is very short and we are going to get bombed and bursted by this volcano, more than a world war. It is the worst world war that we are having now. Coronary artery disease per se, isn't it? So there are lots of treatment advances have come in coronary artery disease. One is the thrombolysis and different algorithms, and the ICU care, defibrillators, ventilators, intra-aortic balloon pumping, coronary angiograms, CT angio, stress testings, PTCA stents, selective PTCA, the drug-eluted stents, rescue angioplasty, CABG, beating heart surgery, pinhole surgery, MRV antagonists, and then the angiogenesis, stem cell research. So many advances have come. In spite of this, the disease is not under control. Why? The risk approach is not followed. You have to follow the risk approach. Remember, all of the above here are prohibitively expensive and not accessible to all. So the best approach would be what? Benefit the lucky few who survived until the hospital door, and the best palliative. Bypass is only a bypass to the problem. It doesn't remove the problem. Bypasses the blocked arteries. Blocked arteries continue to exist and new arteries get blocked. Bypass, don't think it is a treatment. Bypass is only a bypass. So they are at best palliative and not a curative. Then what should be the CAD scenario? 100 out of 100 cases of myocardial infarction, 20% die whatever you do or not do. 100 people get myocardial infarction, 20 of them die. Blessed there, no problem. There's no intervention doctors. Of these 20, 14 of them die even before they see the doctor, even if they before they come to the doctor. That means 14 out of the 100 cases perish before the doctor see. You will be hearing, he was all right talking, suddenly he collapsed, he died. This is a story with 14 of the 100. Pre-hospital mortality is very, very high. Remaining 6 out of the 20 who die, they die in spite of you. That means they come here, you don't properly manage them and they die. That is called, in spite of the doctors, they die 6 people. Some more may perish because of us. That is, iatrogenic causes. And 2 to 3% of sudden cardiac deaths are 2 to 3% are sudden cardiac deaths out of these. That means without any knowledge, any warning or any indication, suddenly the fellow drops dead. I have one physician, surgeon, who is a gastroenterologist surgeon, a very famous person. He's my friend. He is 52 years. I was then at around 55 or something like that. So he went to his washroom in the morning and he died on the spot. Just like that, he collapsed and died. When we did the autopsy, his hospital this is his house, next door is our hospital. They brought him to the hospital and did everything possible. Nothing could be done. Massive thrombosis of the coronaries. In this very hospital, Venugopal, one neurosurgeon used to be there around 1.5 years, who operated on my aunt on this Thursday. Next Thursday, the same gentleman, Venugopal, he went into the theater, washed himself well, about to open the cervical spine for a surgery, called his relatives of the patient, explained everything to them that this is what he's going to do. And those people are very happy. Okay, doctor, you start. He was about to start, washed and ready, about to anesthetize, just reducing the anesthesia. He dropped dead in the theater here itself. This is 1.5 years back. He is hardly 45 years. I don't know whether you know that gentleman. Yes. They have all pulled some money also and tried to help the patient. And we meet, and the cardiologist is there, surgeon is there, everybody is there. Next room, they are shifted to the ICU. Nothing could be done. Why? He never underwent any checkup for the last 5 years. His wife says he hasn't gone for any checkup whatsoever, including blood pressure, sugar, cholesterol. What a foolish person he is. He may be an intelligent surgeon, a very foolish man. Indeed, he sacrificed himself. Had he just detected a little earlier, it could have been managed. His brother also died, it seems like that, sudden cardiac death. So these don't come after, giving a lot of warning and a big long rope to carry and then caught unawares. Sitting here, immediately perished. My friend there, some 15, 20 years back, and this man around 1.5 years back, are 2 senior medical men dying on the spot, a neurosurgeon and gastrosurgeon. Why I'm telling these stories? Because it is such an important thing. You don't give any value for prevention. Somebody comes with heart attack, what shall I do? This stenting, that stenting, this bypass, that bypass you are thinking, which are all palliative procedures. And there's no needless to say, these cardiac interventions are at best palliative. Everything is there in your hands to prevent the disease. 1/3 of the cases of myocardial infarctions are silent myocardial infarctions. They increase the risk of death. Among 80 survivors, therefore 25 people died out of 100. 80 are survivors. Reinfarction is 30% of them will become reinfarction within the first year. Restenosis and failure of the PTCA occurs in 25%. 10% of the survivors, LV diastolic dysfunction and systolic dysfunction is a persistent problem and they're chronic invalid. That's why we studied heart failure in such a great length. Okay, so this is the scenario. We are all, anyway, our generation is over. You are the people who are going to prevent yourself first and prevent the communities from this onslaught, particularly male gender and smokers. Okay, so once we are a patient of MI, we are a permanent patient, plus or minus invalid. The question is whether you are invalid or not invalid. That's all. You are a permanent patient. Once you are a patient, you are a permanent patient of the cardiac this one. How to win this battle? Now we know this is a big problem. How can I help myself and how can I help the community? Coronary care units cannot answer all the callers because the disease burden in this country is so heavy. Increasing the number of coronary care units at best can serve a privileged few. PTCA and CABG are not always available and feasible, are affordable by are not affordable by many, and available in many centers they are not available. Why make a valiant attempt to save the myocardium after all the damage is done? Is it better to not to step into the mud, or is it better to wash the feet after stepping into the mud? You tell me. Any intelligent man will not put his foot in the mud in the first place. But having somehow got it, you have to wash it. That's secondary thing. All these treatments are only like that. Washing the mud after you become muddy. Why do you become muddy and murky? You have to ask yourself. Why not protect our tiny blood vessel pipes by adopting preventive strategies at very low cost? You know the size of the coronary is 2 to 3 millimeters. How much time it will take for 2 to 3 millimeter tube to be blocked by your vada, dosha, chicken, and all these things? Whatever nonsense we are eating, 2 millimeters pipes, how long, how much time it will take for them to get blocked? Choice is yours. Listen or perish. There are only two ways. Choice is yours. Listen to the advice here or perish. That's all. There's no other choice. Prevention is the only best weapon. Need to identify those at greater risk, target them early, and forestall the damage. CVD, is it preventable? Yes, yes, yes. The risk assessment must start very early, not at 60s, not at 55. Start at 20. Risk assessment should start at 20. We have evidence to say that atherosclerosis starts as early as 15 years of life. At 15th year of life, atherosclerotic plaques start coming up. So at least at 20, you start evaluating. Healthy lifestyle and heart healthy eating habits are only way. Regular physical exercises from a young age, you are old enough for the exercise. You should have started at least 10 years earlier. I have started like that. When I'm 15, 20, I started regularly doing all the physical exercise. Even today, 1.5 hours in the gym and 10 kilometers of walking, I'd be even now, at the age of 75. Can you imagine how fitness is not a gift from elsewhere. Fitness you have to earn. Health is money. How do you get money? First you have to earn. When you earn money only, you can save it. If you don't earn health, how can you save it? Health should be earned. It is a thing you can earn now and earn the health, save it for future. This should be your dictum. Maintaining ideal weight and hourglass waist. A beautiful Ajanta Silpa-like thing, not an all-rounder cylindrical weight. All rounders, all are all-rounders. All over. There is no other shape, only one shape, round shape. Where is the Ajanta Silpa nice waist has gone? 15 years girl may have, 20-year boy may have. After that, only pot bellies, like 9th month pregnancy, whether lady or gent. Yeah, everybody is pregnant. You go and see on the road. Everybody is 9th month pregnant, including men and women. Pot belly, abdominal obesity. What pregnancy you want? It's not a child, it is inside a time bomb. And so all the fat is a time bomb. Avoid tobacco and reduce alcohol. There are enough guidelines. We are not dearth of having international guidelines. Open the internet, open the book. Every year they keep on revising guidelines. Who is implementing? Guidelines without implementation, what is the use? Laptop you have purchased, when never used, what is the use? Car you have purchased, never used the car, what is the use? Body you are given, you never properly use it, what is the use? Find out for yourself, reflect. I want to sensitize you, that's why I'm a little emphatic. Okay, see there, risk factors. There I have to catch endothelial dysfunction, atherosclerosis, coronary artery disease, myocardial infarction, ischemia, coronary thrombosis, then infarction, arrhythmia, muscle loss, LV remodeling, ventricular dilatation, congestive heart failure, end-stage heart disease, and of course the grave. Grave is already there, ready. Even at any stage you can go into the grave. Grave is ready. Only thing is when. You have to. So where do you intervene? Would you end-stage heart disease? You start giving, cardiac bypasses and all the heart transplantations you would like to do, or stem cell research, or prevent at the risk factor level. Which should be the easier one? Which should be the feasible one? You look at there. Intervene there. Not after the coronary artery disease develops. I am sorry, whoever wants to diagnose coronary artery disease as a disease, he is a poor physician. Whoever prevents coronary artery disease, he is the real physician. He is the real cardiologist. Not the one who does bypass, not the one who puts stents. He is not a cardiologist for me. If you ask me, he is not. Okay. Now you see, low risk. We are born by given beautiful life by our mothers with a low risk status. Multiple risk factors are there. Primary prevention, subclinical atherosclerosis, other atherosclerotic manifestations, secondary prevention, post-MI and angina. So these are the various levels. Where do I intervene in this pyramid? Not at the top. I should intervene in the blue level at the right at the base. Okay, you see, that is the beautiful capillary that each one of us has. There are endothelial cells and there is a basement membrane beneath the endothelial cells, and you have the nucleus of the endothelial cell, and capillaries are tight and not impermeably there. The endothelial cells are adhering to one another, and there is no leak of lipids into the subendothelial layer. The basement membrane is strong. This is not the individual endothelial cells. Now what happens? There will be holes in the endothelium. The fenestra will start appearing, and then there will be leakage of all proteins, and then blood vessels, everything into the subendothelium. Once the endothelium is damaged, the whole thing is damaged. Endothelium is the largest vascular organ, largest endocrine organ in the body. And endothelial dysfunction is the common soil for every disease which we have thought of, like including your PCOD, your infertilities, your erectile dysfunctions. Everything is a feature of endothelial dysfunction. How does this endothelial dysfunction occur? This is the beautiful normal blood vessel pipe that is given by my mother when I am born. What I do? I eat all junk and make it an apoptosed endothelium like that. And that apoptosed endothelium is leaky endothelium. It is weeping all the time. You are not helping the endothelium and its cause. Now you see, what are the factors? Coronary risk factors, of course, genetics, endothelial dysfunction, low nitric acid oxide, inflammation, thrombosis, and then the coronary artery disease. Nature, genetic conspires with the nurture or acquired. Nature and nurture. Nature is the genetics, nurture is what you eat and how you live and what exercise you do. These two together conspire to produce the damage. Now, endothelium and nitric oxide. Endothelial cell, that is the endothelial cell L-arginine, is converted into nitric oxide by oxidation using L-citrulline as the enzyme. L-citrulline is produced and NO synthetase is the enzyme, and L-NMA is N-G-monomethyl L-arginine is enacted on that, and L-citrulline is produced, nitric oxide is produced. This nitric oxide is coupled with the guanylate cyclase to produce GTP and cyclic GMP, which dilates the blood vessels, which keeps the blood vessels healthy, which keeps the endothelium intact. This nitric oxide at the endothelium is generated every split second. Molecules of nitric oxide are generated by the NO synthetase. What happens? Acetylcholine and other drugs, other chemicals, they interfere with the NO synthetase, and nitric oxide is not produced. Now you see, this is the beautiful endothelium when you are probably 15 or 20 years. Then there is vasodilatation, thrombolysis, platelet disintegration, anti-proliferation, lipolysis through various factors that are listed there. Nitric oxide, PG12, EDF, EDHF, many other factors that are there. Same beautiful green endothelium by endothelial dysfunction, we have converted into a useless endothelium. Vasoconstriction, thrombosis, adhesion molecules, growth factors, inflammation, all these take place simply because we are not eating right and we are not exercising and we are not controlling the risk factors. So this is the dysfunctional endothelium and that is the normal endothelium. Now you see, this is the surface of the endothelium. There, so you can see the monocytes are there. These monocytes are now, they sneak into the into the subendothelial, this one. Once the monocytes enter inside, they become macrophages, and the LDL, once it is oxidized, LDL gets underneath the endothelium. Oxidized LDL is gulped by the macrophage, and that becomes a foam cell, and that produces a huge cell with all the cholesterol-laden cell inside, and that is thrombogenicity and vascular inflammation. First of all, who is allowing the LDL fellow to go inside? LDL, when it is oxidized, it becomes LDL, when it is oxidized, it becomes permeable into the subendothelium. What causes LDL oxidation? Lack of nitric acid. If nitric acid police is there on the surface of the endothelium, LDL has got no business to enter inside. LDL is oxidized and starts producing all the problems. So smooth muscle cells are there, they proliferate and produce vasoconstriction. Now you see, nitric oxide is the police there, which stops policing the endothelium. LDL inside the endothelium is dangerous. Oxidation of lipids and apoprotein B aggregation, modified LDL. Modified LDL is pro-inflammatory in the intima, hydrolysis of the phosphatidylcholine to lysophosphatidylcholine and other chemical modifications. This policing is done by the nitric oxide outside. Without the nitric oxide, LDL gets oxidized. Oxidized LDL is like a time bomb. It goes inside. Now, the monocytes are there. Monocytes start leaking. Why? Monocytes that is MCP1, that is the monocyte chemotactic protein 1, will attach the monocyte onto the endothelium and squeeze it into the endothelium, underneath the endothelium. That engulfs the LDL that has come, and that modified LDL and the monocyte together will form foam cell, and that is the debris under the endothelium causing the plaque formation. Now you see here, modified LDL promote the differentiation of monocytes into macrophages, and modified LDL converts monocyte into macrophage, and that produces the further damage. Further addition molecules, cytokines, macrophages, modified LDL, and then damage to the subendothelial structures. Now you see beautifully the MCP1 has come, VCAM, ICAM, all addition molecules have come, E-selectin, P-selectin, these are all there, and these produce the foam cells or macrophages, which are the deposition of the cholesterol under the endothelium. This is how the plaque buildup occurs. Now you can see in this diagram, this is all molecular mechanisms involving the atherosclerosis that I am showing here. Anyway, the PDF will be with you. The remnants of LDL lipoprotein remnants, VLDL remnants, they also enter and then damage the endothelium there. And now you see nuclear factor kappa B, the endothelial cells, angiotensin 2 is there. Angiotensin 2 under the influence of nuclear factor kappa B activates smooth muscle cells, and that produces interleukins and CRP, MCP1 addition molecules, and VCAM, DICAM are produced. These are the angiotensin 2 is a pro-inflammatory mediator. We have already seen about the angiotensin 2 earlier. So what happened? Now, there is a plaque formation, and the plaque that is formed, it has now ruptured there. A ruptured plaque calls of the platelet adhesion, platelet activation, platelet aggregation, and thrombotic occlusion. So this is a non-vulnerable atherosclerotic plaque, non-ruptured, which can go into a vulnerable atherosclerotic plaque. If you have a plaque without vulnerability, it is okay, but when it becomes vulnerable, why it becomes vulnerable is important for us to understand. Atherosclerosis is a progressive process. Normal blood vessels, fatty streaks, fibrinous plaques, occlusive atherosclerotic plaque, and then finally plaque rupture, fissure, and thrombosis. This can cause unstable angina, myocardial infarction, coronary death, stroke, and critical leg ischemia, which we have seen in the PAD class. That here in this stage before the myocardial infarction, effort angina will be there, and all these stages it is clinically silent. Until it comes here, clinically patient will not have any symptoms. If you ask him, do you have chest pain? No. Send him away. He is pot-bellied, hypertensive, diabetic, dyslipidemia, smoker. You did not do anything because you did not have chest pain. Chest pain is the last thing that you will get it. Why do you wait for symptoms? Why don't you interfere when there is enough evidence of the risk factors are there? Okay. Now, so this is the lipid core you can see there, and the fibrous cap is there on that, and lumen. If the fibrous cap is strong, there, the fibrous cap, this lipid core will not escape into the lumen and cause thrombosis. If the lipid cap is very weak, then suddenly it will rupture and produce sudden cardiac death and occlusion. Now, what are the mediators here? Macrophages, foam cells, activated intimal smooth muscle cells, and normal medial smooth muscle cells. You can see normal cells are like that. The activated ones, they cause the plaque rupture, the anatomy of the atherosclerotic plaque. Now, this is an intravascular ultrasound. But you can see this is an ultrasound taken by an ultrasound equipment positioned within the blood vessel to show the plaques there. The fissures in this fibrous cap produce thrombotic occlusion. It's an intravascular ultrasound. Now, so many risk factors. What are the risk factors? Malaria, only one parasite. Maybe 4 different ones. All are amenable to that drug. No problem. Tuberculosis, one definite bacterium. 4 drugs you treat, diagnose and treat. We have won those things. Malaria and tuberculosis are re-emerging, but nonetheless we could conquer because there is one disease, one cause. HIV ain't one deadly virus, probably under control by various mechanisms. But CAD, there is no one specific cause. It is the largest non-communicable disease, multifactorial in its causation. The more ignorant we are about the causation, the more risk factors we have to add to the list and try to explain. It's a multifactorial disease, largest non-communicable disease. Now I am classifying. Now, where you find this classification? This is a new classification. We have made markers and makers. Makers and markers. So markers and makers. Makers means those which are direct risk factors. Markers are the surrogate tests. That is secondary tests. What are the makers? Which are predisposing to the risk, coronary risk. So, okay, modifiable risk factors. The tough 6. Non-modifiable risk factors, modifiable risk factors, modifiable the contributing 6. The tough 6, the conventional 6, and the contributing 6. Markers, surrogate tests, we rarely care, simple 6. Barely know, complex 6. Rarely needed, experimental 6. So we are going to see the presentation under these 6 headings, markers and makers. And under the makers, we are going to see non-modifiable, modifiable, and contributing risk factors. Under the markers, we are going to see rarely we care, but very important, simple test. Barely we know about them, we don't even do that. Rarely we need some of the newer risk factors. If non-modifiable, why should I study? You are saying non-modifiable risk, it's not modifiable. Why should I study? Because to know the risk status. Suppose a person is there, age is 60 years or 65, male gender. I can't reduce the age, I can't change the gender. But why do I know? To prognosticate about the disease and tackle the disease in a proper manner. So non-modifiable risk factors like age, gender, ethnicity, family history, premature coronary artery disease, phenotype B and type A personality. These 6 are the non-modifiable risk factors. Age, gender, ethnicity, family history, premature coronary artery disease, and phenotype B and type A personality, partly modifiable, of course. These are the non-modifiable, the tough 6, we call them as the tough 6. So, what are the modifiable ones? The conventional 6, diabetes mellitus, dyslipidemia, hypertension, smoking, tobacco, overweight and obesity, and physical inactivity are the 5 or 6 modifiable risk factors. Okay, so contributing 6, HSCRP, LPA, SLDL, endothelial dysfunction, ApoB/A1 ratio, and homocysteine are the contributing 6. Now, I am showing you once again for those who are sleeping. Okay, non-modifiable risk factors, age, gender, ethnicity, family history, premature coronary artery disease, phenotype B, type A personality. Modifiable risk factors, conventional risk factors, diabetes, dyslipidemia, hypertension, smoking, tobacco in any form, overweight, obesity, and physical inactivity. And now we have got the contributing risk factors, HSCRP, LPA, SLDL, endothelial dysfunction, ApoA1 by B ratio, and homocysteine. Now, we rarely care to identify the simple ones, waist circumference. The easiest way to measure cardiometabolic risk is the waist circumference. That is the stethoscope of cardiometabolic risk. Endothelial dysfunction. We have to ask patients about endothelial dysfunction. Ankle brachial index, intermittent claudication, and pedal pulse should be examined for everyone. Pulse pressure, important for isolated systolic hypertension. Microalbuminuria is the very important early risk factor which you can screen. And echocardiography, ECG, and X-ray routinely for LVH. LVH is the single most predictor of mortality and morbidity in coronary risk. Now, barely we know ABPM, ambulatory blood pressure monitoring, dippers and non-dippers. The non-dippers are having a higher risk for cardiovascular disease. Brachial blood flow mediated dilatation, FMD, polycystic ovarian syndrome by ultrasound, CIMT, carotid intima media thickness, FFAG, fluorescent fundus angiography, and stress thallium scan perfusion studies. These are the complex things which we don't require to do in all the patients. But nonetheless, in selected patients, they are useful. The experimental one, C-peptide as a measure of cardiometabolic risk, not for insulin resistance, as a measure of cardiometabolic risk. Uric acid, fibrinogen, plasminogen activator, inhibitor, inflammatory markers, SICAM, ICAM, serum amyloid alpha, interleukin 6, metalloproteases, and subfractions of LDL and HDL, intravascular ultrasound, and of course, now today we also have obstructive sleep apnea and fatty liver. You have to add these two also to this list of other risk factors like obstructive sleep apnea and fatty liver and uric acid, of course, it is already there. Now, what are coronary risk equivalents? You may get a short note. Discuss coronary risk equivalents, which are equivalent to coronary having a heart attack. One, diabetes mellitus itself is a coronary artery disease risk equivalent. Peripheral vascular disease, PVD, Framingham risk score of more than 20. Carotid artery disease like stroke or TIA, more than 50% narrowing in the carotid Doppler and carotid bruit, abdominal aortic aneurysm, AAA, are called coronary risk equivalents. That means they are as though you have already got a heart attack. Somebody is diabetic is as bad as a person who had a heart attack. Peripheral vascular disease, Framingham risk score of more than 20, carotid artery disease like TIA, stroke, narrowing of the carotids, carotid bruit, abdominal aortic aneurysm. Okay. Non-modifiable risk factors. Age, gender, ethnicity, family history of premature coronary artery disease, phenotype B, and type A personality. We need to know a little more about each of these factors. Now, we look at the age first. Coronary artery disease increases as age advances. Men more than 45, women more than 55 are at higher risk. CADI is 10 years younger. Coronary artery disease in Indians is 10 years younger in this country. Men suffer CAD 10 years early. Increased longevity, aging population, increased duration of risk exposure, multiplicity of risk factors, treatment responses are blunted in most of these people. So age and coronary artery disease. Then comes the gender. Gender-wise, coronary artery disease is the disease of the man, a myth. Woman coronary artery disease is atypically present. Volumes are written as CAD in women. Silent MI more common, particularly in women. 10 years later, first attack mortality more common in women. CAD deaths are twice those of all cause cancers. CAD deaths double the number of deaths due to cancers. Diabetes mellitus is a more powerful risk factor for women. If a woman is a diabetic, she is having greater risk for coronary artery disease. Increased triglyceride, LDL, decreased HDL are common factors found in women. Physical inactivity, abdominal obesity, needless to say, they are very common in women. Now, Indian women are men. When does a woman becomes man? Indian women compete with men in CAD rates. Indian women are notoriously men. Women CAD is one of the highest. CADA women in India, CAD in India, highest on the globe. In other parts of the world, women are relatively protected until they are in the reproductive age. Premenopause, I'm a woman, enjoy the protection. Either surgical menopause or natural menopause depletes the estrogen. Estrogen protection is annulled after menopause. Also, if the woman has LPA more than 30, woman becomes man. If she has developed type 2 diabetes, IGT, IFG, PCOS, gestational diabetes, that woman is already a man. She has a central adiposity. Who is not having central adiposity? I am yet to find a woman who is not having central adiposity. If she is a smoker, again, I went to find a woman who is about 30 years. Very rare. Only on before marriage, maybe a few of them, yes, not after that. Everyone is abdominal obesity. She is a smoker. So when does a woman become a man? After menopause, surgical or natural, or LPA more than 30, or developed type 2 diabetes, IGT, IFG, PCOS, GDM, central adiposity, and is when the woman is a smoker. Now you see, coronary artery disease mortality trends over 20 years. You see, the males it is decreasing. In the woman it is almost stationary or increasing. Okay, you see, heart disease and breast cancer. Breast cancer is coming down because of the mammograms and then the self-examination of breast and better treatment. Coronary artery disease is increasing over the decades. So, wise study review of ischemic heart disease in women, you see 35 to 45, atypical angina, non-anginal chest pain. Three colors. Typical angina red, atypical angina blue, non-anginal chest pain yellow. That is 35 to 40. 45 to 55, you see the rates. 55 to 65 increasing, 65 to 75. Typical angina is very much more. In the wise study, when we have seen, these are the heart disease in women. Then comes the ethnicity. Ethnicity, needless to say, Indian ethnicity is very prone for coronary artery disease. Japanese and Chinese have the lowest rate of coronary artery disease, while Caucasians and whites have lower rates. Hispanics, that is, the Spanish-speaking people, intermediate rates. Asian Indian higher rates. Afro-Caribbeans the highest rates. Among the various ethnic studies, we rank the fourth from the bottom, that is the Asian Indians. Higher rate, still worse are the Negroid race or the Afro-Caribbeans. Now, coronary artery disease in India is called CADI, C-A-D-I. CADI strikes early, CADI strikes hard, CADI strikes almost everyone unnoticed, CADI strikes unexpectedly. Conventional risk factors cannot explain it away. When we ask, a patient who had myocarditis, he is not hypertensive, he is not obese, he doesn't have this one, he regularly goes for walking, he plays tennis, he doesn't smoke, he is 40 years, but he died. Because we cannot explain coronary artery disease in Indians. It is malignant in its onslaught. That's why I said they are all sitting on a volcano. If you see the death rates of coronary artery disease, Japanese are at the bottom, and then the China and Russians and Scotland are on the top, and Finland and England are somewhere, USA are somewhere in between. Where are we? There is no place in the graph. It is beyond Russia and it goes beyond the screen. That's why it has not come there. Indian bar, it doesn't fit here because it is 10 times more. I have to go and put it in the other room, I have to project, not in this room. This is the coronary artery disease mortality in this country. Okay. Okay. CAD volcano. We are on the middle of the wave of CAD epidemic. Epidemic is not only COVID. COVID and diarrhea epidemics are short-lived. They come and go. They kill millions, COVID and all, but then they won't come back that easily. Coronary artery disease is a chronic epidemic. It is there. CADI epidemic will peak by 2015, we projected. Now already it has peaked in 2006 itself, it peaked. Now we are already 2026 now. You see, 50% of the deaths in India are CVD deaths. CADI will overtake infectious diseases, morbidity also. CADI will be 6 times more than in the West. It is true. CADI is 20 times more than Chinese, although our culture shuns smoke. Remember, 50% of our population women population are non-smokers. 50% of the population do not smoke. Whereas in Western countries, all women do smoke. In spite of smoking not being there, Indians have such a culturally, which 50% of the population are vegetarians in India, either by lack of money to buy non-veg or by their habit they're vegetarian. In spite of it, coronary artery disease is very high. We lack many other classical risk factors of coronary artery disease. Remember, coronary artery disease is preventable and predictable. That is the beauty of all the presentation. Suppose if all the story is not preventable, then why we make a big presentation and shout about it? So it is preventable. So now, CADI study. So 14% of Asian Indian males, 5% of females have optimal HDL. Only 14% of Indian males and 5% of females have a HDL of more than 40. You see any report, 30, 32, 28, 30. Very rare to see somebody who has got more than 40. Okay? So in men and women, so very few people, Indian patients with CAD, high triglycerides are found more often than high LDL. High TG, low HDL is the Indian type of presentation. Now, family history of premature coronary artery disease. Invariably, you must ask for this. What is family history of premature coronary artery disease? Any blood relative, male or female, dying of coronary disease or any cardiovascular disease before the age of 65 in women, before the age of 55 for men. Any relative, blood relative, not the spouse. Spouse is usually not a blood relative. So the brother, sister, father, uncle, aunt, mother, son, daughter, any one of them who are direct blood relatives, if they have perished due to coronary artery disease, or if they had coronary artery disease before 35 years of for the men relative, and before 55 men relatives and 65 women relatives is called premature coronary artery disease. This must be elicited: age, gender, ethnicity, premature coronary artery disease. CAD is in the first degree relative, male relative before the age of 55, female relative before the age of 65. Aggressive risk approach is required. Look for, who's that? Sorry. Look for non-conventional risk factors, LPA, SLDL, and decrease in the HDL are the main culprits. If you want, you can sit down and listen, otherwise. Sorry, sir, I just want to know till what time is the class? 1 more hour, half an hour more. Okay. By 4 o'clock it will be over. Okay. Okay. Coronary artery disease calcification, CAC. Coronary artery calcification, you may be doing a lot of calcium scores and family history there. Number of risk factors, no risk factors, 1 risk factor, 2 risk factors, 3 risk factors. Adjusted prevalence of CAC score. The more the number of risk factors, the more is the coronary calcification. Now, phenotype B. What is this phenotype B? This is the apoprotein phenotype. And there are 2 types of phenotypes available in the world, phenotype A and phenotype B. Indians by default are phenotype B, which is the dangerous phenotype. That's why we have a lot of coronary artery disease. 85 to 90% of Indians are phenotype B. I can check it for you. You can check it in the lab. What type of phenotype? There are 2 types of phenotypes for lipoproteins A and B. Phenotype A is heteroprotective. Phenotype is heterogenic lipoprotein. ALP, heterogenic lipoprotein. B will be there. They have a low HDL, high LDL, and high TG. How do I know? HDL will be low, LDL will be high, and triglyceride will be high. Now, nature conspires with the nurture. There is an article, the interaction between the current genotype and our present day lifestyle and eating habits places us at a very high risk of having this phenotype B that makes us highly susceptible for atherosclerosis. It's nature and the nurture. Nature is the phenotype B, and we all have all the beautiful bad habits with us. Tell me what are all the bad risk factors, all of them are there with us. Phenotype B or atherogenic lipoprotein, ALP. This is not alkaline phosphatase, heterogenic lipoprotein. ALP or phenotype P is present. It's seen most often in insulin-resistant individuals, in diabetic, obese persons, sedentary lifestyle, more prevalent in India. ApoB by A1 ratio will be more than 1.5. That's why you have to measure ApoB by A1. If ApoA1 is more, it is phenotype A. ApoB is more, it is phenotype B. Okay. Characteristics of LDL, the phenotype B. It is common inheritable trait, frequency 30% of the population, autosomal dominant inheritance, reduced penetrance, associated with increased TG, LD, VLDL, intermediate density lipoproteins, and decreased HDL2 threshold for increases for myocardial infarction, after particularly in the premenopausal female. Now you see, this is the triglyceride phenotype A and phenotype B. Phenotype A, you see the triglyceride levels, TG levels, and the cumulative frequency. They are very much in phenotype A, very lower. Whereas in phenotype B, you see large amount of hypertriglyceridemia in phenotype B. Okay, phenotype B and then the HDL. HDL is very much higher in the phenotype A. You can see the high graph here, and it is very low in phenotype B. That's what I told you. And finally, type A personality. What is type A personality? Type A personality always chasing goals, very tensed, sympathetic drive is more, always wants to be the number one, and very competitive, and never relaxes, and doesn't find time to smile even. That sort of person is a type A person. Type B personality, work is worship, okay. But then with the work, you should also have a sort of relaxation for the mind, body, and the hormones. Everything. So adequate sleep gives you better personality to handle. That is type A personality. TABP, type A personality, type A behavior pattern, it is called. TABP, impatient, time urgency, strong desire to achieve more in less time, free floating hostility, ever irritated, unwanted anger, unable to relax, have too many to-do lists and never ends, highly competitive, very ambitious, always grinding the teeth and clenching the fist like that. That is type A personality. Type A personality, it doesn't feel the time urgency, takes things lighter, and then anger, the other things, negative emotions are very less in such a person. A relaxed person, type B, a tensed up person, type A personality. I can change their personality slowly by behavioral training. Okay. These are all the non-modifiable risk factors. What are the non-modifiable risk factors? Age, gender, ethnicity, then the type A personality. And then you also have the phenotype A, B. These are all family history, coronary artery. Age, gender, and then family history of coronary artery disease, type A personality, then phenotype B. Yeah. These are the non-modifiable risk factors. Then comes to the modifiable risk factors, the big six. Diabetes, dyslipidemia, hypertension, smoking, overweight and obesity, physical inactivity. Tell me who doesn't have it. Go and sit in the OP and check the reports. You will find almost smoking may or may not be there. Remaining five are already there. Obesity, take it for granted. Everybody is obese. Physical inactivity, no one wants to work. And always a table job, sitting job, couch potato, mouse potato, either TV or some screen, mobile phone. Nowadays, and it goes on watching unnecessary, useless videos and the charts. The mobile phone even further killed. TV itself murdered. This is a double murder. This mobile phone and iPad. Okay. So that is physical inactivity is there. Smoking, some of them are having that. Hypertension, an end result of all the today's stress. Dyslipidemia, eating habits, and diabetes. We are genetically more prone, and all our environment and eating have. Now, what is the additive effect? You see here, additive effect of smoking, dyslipidemia, and SBP. If SBP alone is there, the risk is 3. If dyslipidemia alone is there, risk is 4. If smoking alone is there, 1.6. If 2 of them are there, 6. If these 2 are there, 5. If these 2 are there, 4.5. All are there, 16 times more risk. Where is diabetes in those three? It's not there. Diabetes is the background. It doubles the risk. For 1.6 becomes 3.2, 3 becomes 6, 16 becomes 32. Enough? Enough to say smoking, dyslipidemia, systolic blood pressure, they have an additive effect on the background of diabetes. Without diabetes, they are like that. With diabetes, they are like that. This is the relative risk of coronary artery disease. Now you see, relative risk and p-value, LDL cholesterol more than 100, less than 160, hypertension, LDL cholesterol less than 40, triglycerides more than 167, fasting blood sugar more than 126, and then family history of myocardial infarction. All have an increased relative risk of heart disease. The prevalence of conventional risk factors in patients with coronary artery disease. Class is going on. Okay. The prevalence of conventional risk factors in patients with coronary artery disease. You see, no risk factor or one risk factor. How many are there? 62% of the fellows, they don't have risk factors. That means risk factor assessment only can catch around 33. So what I have to do? I should dig deeper. The conventional risk factors are not adequate. Two risk factors, 27%, no risk factor, 20%, and 43 is one risk factor, 8.33 risk factors, four risk factors are less than 1%. So the prevalence of conventional risk factors in coronary artery disease on a large population of around 90,000 people, when studied over a long term, this is the result. Now, what I should do now? I must look for non-conventional risk. What are the multiple risk factors? The gang of BP less 165, 95, 8%. BP more than 165, 13%. More than 56 years, the LDL also is added, 19%. LDL, BP and smoker, 27%. So all these are published data. We have enough data, but we don't implement the message. So diabetes mellitus, no. Dyslipidemia, diabetes mellitus, hypertension, smoking, overweight and obesity, and physical inactivity, the big six. Now, normal values, 100 and 100 to 125 is the EFG, 140 to 199 is the EGT, more than 126 is the diabetes, more than 200. HbA1c between 5.8 to 6.5 is again pre-diabetes, more than that is again diabetes. We have HbA1c also now. The public awareness survey of people with diabetes done in Delhi, it has shown that 68% do not consider cardiovascular disease to be a complication of diabetes. You ask a diabetes, do you think you have a risk of a cardiac? No, diabetes is different. Heart disease, I don't have. This is general feeling. General thing is they don't consider that it is a coronary risk equivalent. Diabetes is a coronary 50+ % do not feel risk of heart condition or stroke. 60% do not feel at risk for high blood pressure or cholesterol because of diabetes. Awareness lowest among the elderly and among the minority. CAD and diabetes, 65% of all deaths in people with diabetes are caused by cardiovascular disease. How do diabetics die? Not by hyperglycemia and coma, they die of cardiovascular disease. 65% of deaths of coronary artery disease, cardiovascular disease deaths are diabetes. Heart attacks occur in an earlier age, in 10 years earlier, they get premature heart disease. 60% of the adults with diabetes have high blood pressure. Nearly all adults with diabetes have one or more of the cholesterol problems, usually high triglycerides in India, low HDL or the good police cholesterol, LDL or the bad cholesterol or thief cholesterol is high. One of the three common manifestation is triglycerides. No, only triglycerides are there, no problem. LDL is normal, that should not be the attitude. Good news, managing ABC of diabetes, that is the A stands for A1C, B for blood pressure, C for cholesterol. And people with diabetes can reduce their risk of heart disease. This is a beautiful news. So somebody is diabetic, he does not have to worry. If he can control the risk factors, his risk for heart disease and stroke can be mitigated or reduced. Atherosclerosis, insulin resistance, and diabetes. Insulin resistance is the forerunner for everything. Insulin resistance produces hypertension, obesity, hyperinsulinemia, diabetes, triglyceridemia, small dense LDL, has low HDL, and hypercoagulability of the blood. All these are predisposing factors for atherosclerosis. Now, CHD mortality and hyperinsulinemia. The more hyperinsulinemia you have, more cardiovascular disease mortality. Insulin levels less than 29 in the fasting plasma insulin to 115. You see how the bar graph is going. The more is the fasting plasma insulin, the more is the risk for coronary artery disease. How many of you are doing fasting plasma insulin as a marker of coronary artery disease? You are not doing, only checking blood pressure, and at best you are looking at cholesterol. You never look at fasting plasma insulin or C-peptide. C-peptide is a surrogate marker for fasting insulin. Check fasting insulin, everybody. If fasting hyperinsulinemia is there, it means he is a candidate for coronary artery disease. Now, progression to atherosclerotic clinical events in patients with diabetes, hyperglycemia, insulin resistance, inflammation, infection, advanced glycation products, oxidative stress, interleukin 6, CRP, serum amyloid alpha, hypertension, endothelial dysfunction. Insulin resistance is a forerunner of hypertension. If you detect insulin resistance, you can prevent hypertension by treating the insulin. Dyslipidemia, LDL more, TG more, HDL low, thrombosis, all these pave way to subclinical atherosclerosis that leads on to disease progression, atherosclerotic clinical event. These are all scientific studies which are published and then evidence is there. Now you see diabetes and CADI. This is done in Chennai. This is Mohan et al. In Chennai urban population study. It is called the CUPS study. This is published in Chennai. When I was there, I was part of this study, Chennai study. Non-diabetic subjects, you see that is there is, and then impaired glucose tolerance, it is 15, and then once he is diabetic, it has an additional coronary disease prevalence of 20%. It is very clearly proved in our own environment. DM and CVA lifestyle study. This is also showing non-diabetics, the risk is 23, diabetics it is 46. Very large population is studied. You can see non-isolated systolic hypertension 25, isolated systolic hypertension is 30. A person who has got diabetes and systolic hypertension, the relative risk is increased so much. The relative risk with diabetes is 2, relative risk with isolated systolic hypertension is 1.2. Now, the Finnish diabetic prevention study, reduction in the risk factors for diabetes, when they intervened and the pre-diabetics are intervened and treated by diet and metformin and exercise, the intervention produced 11% of the people went into diabetes. Without the intervention, 23% of the people went into diabetes in the next 4 years. These are 4-year results. So this all shows that diabetes can be even prevented if you know that the pre-diabetes. Now, dyslipidemia in insulin resistance and diabetes. What sort of dyslipidemia I see? Elevated triglyceride, elevated VLDL, reduced HDL, increased SLDL, and ApoA1 is decreased, increase in the ApoB ratio of B by A are unfavorably increased. This is the diabetic dyslipidemia. All diabetics must be given a statin, irrespective of their cholesterol levels, irrespective of their lipoprotein report. If he is a diabetic, he deserves cholesterol because a statin is not only reduces cholesterol, it prevents other atherosclerotic complications. All diabetics must receive a good dose of statin. Then dyslipidemia. Dyslipidemia is the next important out of the big 6. Dyslipidemia is important. Good cholesterol and bad cholesterol, good, bad, and ugly and deadly. Good is the HDL, bad is the triglyceride, ugly is the LDL, and deadly is the lipoprotein A. These are the normal values: 200 total cholesterol, triglyceride 150, low density lipoprotein 100. Non-HDL should not be more than 130. HDL should be at least 50 in women and 40 in men. So which woman is having 50 milligrams of HDL? Very rarely I can find a woman. Lipoprotein A and it's called little a should not be more than 25. It should be less than 25. ApoA1 baby should be less than 1.5. Now you see risk factors for future cardiovascular disease, and this is a beautiful study which was published with lipoprotein A, homocysteine, interleukin 6, total cholesterol, LDL cholesterol, SICAM, serum amyloid alpha, lipoprotein B, TC-HDL ratio, HSCRP, HSCRP, TC-HDL ratio. You see, lipoprotein to all these things, the risk is increasing more than 1, 2, 2, 4, 5, 6. So 6 times the risk is there with these risk factors. Now, total cholesterol more than 200, 54%. Triglyceride more than 200, 56%. HDL less than 35, 60%. LPA more than 30, 61%. So you can see that dyslipidemia is not at all uncommon. It's very common. Trends in the total cholesterol in the US, you can see men, women, and both the cholesterols are reducing. In our country, they are increasing because we don't copy the good things of the West. We always copy the bad things of the West. Okay, risk factors in CAD, ProCam study, no risk factor, 2.7 hypertension, 3.4 positive family history, 3.9 LDL more than 160, 3.6, 5.6, and then HDL 2.6, sorry, HDL less than 35, 8.3. The odds ratio for the disease. So very important for that. Now, HDL, low HDL is a very good, very strong risk factor. Fasting and fasting TG and risk for coronary artery disease. You see, triglyceride less than 220, more than 220. The risk doubles. And then triglyceride 120, annual mean coronary artery disease, you can see in both the populations. This is the triglyceride less than 120. The risk is on the lower left side, and it is more than 123. The risk is very much more. Now you see. Indian dyslipidemia could be a short notes. Indian dyslipidemia, isolated high LPL, isolated low HDL, isolated high triglyceride. These are the way. This is the triad, and the LPL is high, HDL is low, HDL is low, and triglycerides are high. So this is called the Indian dyslipidemia. So we have that this triad is very important, published from Indian Heart Journal, it is published. And then you can see the diabetic dyslipidemia. Indian dyslipidemia is one type. What will be the common dyslipidemia pattern in a diabetes? Triglycerides are elevated, SLDL is elevated, HDL is low. This is called diabetic dyslipidemia. Heterogenic profile, high LPL, high SLDL, and low HDL together is a heterogenic lipid profile. This is called the triad. And now the reverse cholesterol transport. It's very important. The cholesterol is there in the vascular endothelium. Thus, vascular endothelium, free cholesterol is circulating. And that is the no business to enter into the endothelium. When it is on the epicardial surface, it cannot go inside the endothelium, above the endothelial surface. It cannot go unless it is oxidized. HDL will go and bring that cholesterol from the endothelium to the liver. That means it will go, the police HDL will go and capture the HDL from the endothelium, bring it to the liver for excretion, the excess LDL. So this is called reverse cholesterol transport. So there are several steps in that. Not going into go to the details of that. And then you have the reverse cholesterol transport into the liver. So it's a scavenger. Triglycerides predict CAD risk independent of TC and HDL. Whatever may be the HDL and TC, triglycerides by themselves, they predict the risk. As you see, type 3, more than 800 triglyceride, very high risk, 200 to 799, less than 200, and HDL 40. So in all these cases, what we know, the triglycerides increase the risk very much. Accumulation of chylomicron remnants, accumulation of VLDL remnants, generation of small dense LDL, association with low HDLC, increased coagulability, PI1 is increased, factor 7C is increased, activation of prothrombin to thrombin, and this is a hypercoagulable state. Okay, now we'll stop here probably 4 o'clock and we'll see the remaining risk factors from hypertension onwards. In the next class, we have covered the non-modifiable risk factors. We have covered out of the big 6, we covered diabetes, And dyslipidemia, there are several, I have given makers and markers. And out of the makers, I have covered two aspects. And then the markers also are there. Maybe next lecture we'll continue and see. The story of, a message of all the story is that we must try to prevent the cardiovascular. What are the risk factors we must know? Okay. So we'll end here.